This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon, and today we're diving into a topic that sits at the intersection of neuroreconstruction and pediatric quality of life.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Laryngoscope, published in 2026, titled Outcomes and Innervation of Gracilis for Pediatric Facial Paralysis, a systematic review. It's a comprehensive look at how we choose our motor sources when performing free muscle transfers.
This is a crucial topic for our residents and colleagues. Facial paralysis in children is particularly challenging. While it's often idiopathic, the impact on emotional and social development can be devastating. When we talk about surgical intervention, we're looking for more than just symmetry at rest. We're looking for dynamic movement.
Exactly, Dr. Aris. The paper notes that surgical interventions are indicated for pediatric patients with complete paralysis, aiming to restore facial expression and oral competence. For a long time, free functional muscle transfer, or FFMT, has remained the gold standard, and among donor muscles, the gracilis is the most commonly utilized because of its reliability and consistency.
Right, the gracilis is the workhorse here, but the real debate, and what this systematic review tackles, is the innervation technique. How do we power that muscle? Dr. Alara, walk us through the search strategy and the patient population this review covered.
The authors queried PubMed, Scopus, and Senile through late 2025. They looked specifically at pediatric patients under 18 undergoing gracilis-free muscle transfer. They identified 15 retrospective studies. The mean age at the time of surgery was quite young, 9.0 years, with a mean follow-up of about 3 years.
That's a significant window to observe growth and axonal regeneration. Now, let's get into the 3 pillars of innervation they discussed: the cross-facial nerve graft, the masseteric nerve, and dual innervation.
Right. In this cohort, cross-facial nerve graft, or CFNG, was the most common, used in 52.1% of cases. Masseteric innervation followed at 33.2%. The paper describes CFNG as the pathway to spontaneous and synchronous movements. However, as we often discuss in the OR, the downside is that it's usually a 2-stage procedure with an extended wait for axonal regeneration through the nerve graft.
And for a child, that wait can feel like a lifetime. Contrast that with the masseteric approach.
The motor nerve to the masseteric allows for a single-stage procedure. It's described as a reliable and strong nerve, providing non-spontaneous, voluntary motor control. The paper highlights that this is essentially a trade-off. You get stronger movement, but it's a conscious effort, usually biting down to initiate the smile.
This brings us to the balanced solution mentioned in the review: dual innervation.
Exactly. Dual innervation combines both CFNG and masseteric inputs. The goal is to couple that reliable motor strength from the masseteric with the natural expressiveness of the CFNG.
Let's look at the hard data. For the residents listening, commissure excursion is the metric we live and die by in these cases. What did the systematic review find regarding the actual movement of the mouth?
This was a standout finding. Masseteric innervation generally produced the largest amount of commissure excursion, with a range of 6.1 to 8.6 millimeters. CFNG also yielded moderate improvements, but in a lower range, 4.6 to 6.9 millimeters.
So the masseteric nerve is objectively stronger. It provides that strong volitional smile the authors mention. But we can't ignore the qualitative side. Did the study look at patient satisfaction?
It did. Despite the differences in excursion and spontaneity, overall satisfaction was remarkably high across the board. We're looking at a range of 83% to 100% satisfaction, regardless of the innervation technique used. It seems that for these children and their families, any significant restoration of dynamic movement is viewed as a major success.
That speaks to the long-term functional deficits these children face before surgery. Even a few millimeters of movement can change how a child interacts with their peers. Now, as neurosurgeons, we're always concerned about the downside. What did the review say about complications?
The authors found that complications were infrequent and minor. This reinforces the conclusion that gracilis-free muscle transfer is a safe and effective technique for the pediatric population. The study used the Joanna Briggs Institute appraisal tool to assess quality, and while most studies were retrospective, the safety profile remained consistent.
It's interesting that despite the anatomical and developmental considerations unique to children, the gracilis remains so reliable. The paper mentions it's chosen for its reliability and consistency in the pediatric setting. When we're in the anatomy lab with the residents, we always emphasize the vascular pedicle and the nerve length of the gracilis. It really is a robust flap for this application.
It really is. One thing I found interesting in the results section was how they categorized the outcomes. They didn't just look at excursion, they looked at facial asymmetry and validated instruments. Even though the studies were heterogeneous, the consensus was clear. Mesenteric innervation is the powerhouse for excursion, while CFNG is the key to that spontaneous smile.
Let's dive deeper into the clinical decision-making aspect. If a resident asks you, based on this paper, which innervation should I choose? How do you answer?
Based on the review's conclusion, it depends on the primary goal. If the priority is the strongest possible smile and a single-stage surgery, the mesenteric nerve is the way to go. If the goal is a natural, spontaneous smile that happens without thinking, CFNG is the standard, despite the 2 stages. But the authors seem very optimistic about dual innervation as the way to bridge that gap, getting the best of both worlds.
It's a classic neurosurgical trade-off: strength versus finesse, single-stage versus multi-stage.
And the paper notes that because facial paralysis in children is often idiopathic and can result in persistent dysfunction, getting the innervation right early on is vital for their social development.
Were there any specific limitations in the data that we should be aware of?
The authors were transparent about the fact that the evidence is largely limited to retrospective case series and cohort studies. There's a lot of heterogeneity in how outcomes are reported. However, by synthesizing 15 different studies, they've provided the most current map we have for pediatric facial reanimation.
That's an important point for our research-oriented listeners. We need more standardized prospective data in this field. But for now, this systematic review gives us a solid foundation. To wrap up, the Gracilis is safe, effective, and the innervation choice should be tailored to the specific functional and aesthetic goals of the patient.
Precisely. Mesenteric for strength, CFNG for spontaneity, and dual innervation for balance.
Excellent summary, Dr. Ilara. This paper from the Laryngoscope 2026 is a must-read for anyone involved in pediatric reconstructive neurosurgery or ENT.
Definitely. It's titled Outcomes and Innervation of Gracilis for Pediatric Facial Paralysis, a systematic review, for those who want to look it up in the Hub's digital library.
That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. We'll see you in the next episode.
Goodbye, everyone.